Good morning to all of you. I'm Giorgio Conti, editor-in-chief of the new journal of the Italian Society of Anesthesia, Analgesia, and Intensive Care Medicine called JAACC, Journal of Anesthesia, Analgesia, and Critical Care. In this journal, very recently, an interesting article dealing with the problem of respiratory support during fiber optic bronchoscopy in critically ill patients with hypoxemic acute respiratory failure has been published by Professor Federico Longhini from Magna Grecia University, Catanzaro, Italy. Today, I have the pleasure to have here the leading author of the paper, and I think it's a very nice, very interesting and clinically interesting paper. And it is my pleasure to introduce him. And I would like that Federico analyze with us briefly the possible advantages linked to the use of high-flow nasal cannula during fiber optic bronchoscopy over the conventional treatments like CPAP or non-invasive positive pressure ventilation. Please, Federico.
Thanks, many thanks to Professor Conti, our editor-in-chief for the Journal of Anesthesia, Analgesia, and of Critical Care, yes, to have accepted this paper in this new journal. Well, this journal, this paper focused on the use of high-flow nasal cannula during fiber optic bronchoscopy, and we have analyzed the possible use of high flow in patients with acute respiratory failure in critical care settings, and we have highlighted how it is important to use high flow nasal cannula rather than a conventional oxygen therapy in patients with mild to moderate acute respiratory failure. So if we have a patient with arterial pressure of oxygen to inspiratory oxygen fraction greater than 150, it will be better to use high flow nasal cannula over conventional oxygen therapy. Why? Well, because high flow nasal cannula, we have recently showed that in another paper by our group, that high flow nasal cannula can assure less the recruitment of the lung, and the proportion of the lung that is aerated is much more during high flow than conventional oxygen therapy. This means that the clinical translation is that the patient has a lower desaturation events, higher minimal saturation during the procedure, and this is also holds true if we do a pool data analysis of the entire literature that we have now. In addition, it should be mentioned also that patients with moderate to severe acute respiratory failure would more benefit than of CPAP or NIV rather than high flow nasal cannula. Why? Because these patients have needs higher distending alveolar pressure, so high flow, although high flow may produce a low positive and exhalatory pressure, the non-invasive ventilation or CPAP through helmets would be preferable because they reduce the number of desaturations.
Thank you, Federico. And I have another question for you. What about patients with hypoxemic acute respiratory failure generated by COVID-19? We are unfortunately in pandemic at times. Is it what you told us is can be adapted also to patients with COVID-19 infection, or we have to modify our approach?
Yeah, the COVID-19 epidemics is a big challenge for all clinicians. There is the fear of infection of the personnel, so and of clinicians. So first of all clinicians should wear the full personal protective equipment. That means the FFP2 mask, the gloves, goggles, face shield, and gowns. So they are definitely required, and certainly they are required. In addition, if we use high flow nasal cannula or other or other equipment for ventilatory support, the literature said that the high flow nasal cannula has a high dispersion that is around 900 millimeters. So around is a really short dispersion of the air around the patients, and this dispersion of the air is also limited in case of helmet CPAP or helmet NIV. But this is not all true if we use a face mask with exhaled port, so with specific design mask for non-invasive ventilation that are equipped with a air leaks dispersion system. Why? Because in these exhalation valves or through these holes, the air has a dispersion that is around 1 meter. So the distance between the patient and the clinicians could be somehow violated by the dispersion. So if we need to do a bronchoscopy in a COVID-19 patient and the patient has a PO2 VO2 ratio greater than 150, it will be possible to use high flow nasal cannula. Otherwise, if the PO2 VO2 ratio is lower than 150 and the patient is not intubated, it should be preferred to use helmet CPAP or helmet NIV.
Thank you, Federico. This is very interesting. I hope that all enjoyed this short discussion. We will repeat this experience for further articles that will be published in our journal. I thank you for your attention. Bye-bye.